Great. Well, good morning, and thank you very much for inviting me. I have to say, it was absolutely fabulous to get off the 6:30 train from London this morning and walk in the venue, and the sheer level of energy that was out there was just, I was thinking, we're with the can-do people today. Fantastic. So thank you for that. I suppose I better explain a little bit about who I am. So up until this last couple of years, national clinical directors were based in the Department of Health with a predominantly policy role, with an army of 100 people across the country to help implementation. In this new era, national clinical directors, there are 24 of us, are based in NHS England, but we provide advice. I spend probably a third of my time in the DH, a third of my time in NHS England. I work with the Cabinet Office, the Treasury. I work with the Information Centre for Health and Social Care. I'm the data sponsor for that data set. And I work with people in Public Health England. And on a bad day, it kind of feels like every single person in the country who wants somebody who can say they're the National Clinical Director for Mental Health and wants advice can ask me for it. So what I'm going to bring to you today is a perspective across the whole system. I think these are incredibly tough times. Economically, we know that the health service, healthcare in this country is under incredible pressure. We have an aging population. People are living much longer. We have more and more comorbidities. We have to do things differently. And I think you guys have been at the forefront of that movement, and it's tough. But I have to say, I don't think there has ever been a more exciting time to be part of a mental health movement in this country, and I'm going to explain why. I think, first of all, there's a much greater understanding about the causes, the impacts that lead to people having a mental health difficulty, a mental health challenge. My proudest moment, I think, as National Clinical Director was about, I would say, 8 weeks ago, when the Deputy Prime Minister, so we've now got not just the ear of the Minister for Care and Support, Norman Lamb, who's been a terrific ally of mental health, but we now have the Deputy Prime Minister and members of other parties lobbying our cause. And he made an announcement about new ways forward in mental health. And the next day, I was asked, would I go on the You and Yours Question Time programme at lunchtime? And the interviewer said to me, you'll probably need to come on about 5 sound bites because we don't normally get that many people ringing in about mental health. And the total joy for me was that I didn't have 5 sound bites, I had 1 because over 100 people rang in. And the sort of words people are using are really, really powerful. So people rang in saying things like, I was a student, I was at university, I was under a lot of pressure, and my eating disorder came back with a vengeance. I had to wait a couple of years to get good treatment. I've got my psychological therapy. Now I'm going to night school because I want to get back on track with my career. A man rang in. He didn't say, nobody is using the words mental health problem. He rang in, he said, I got really stressed at work. I became depressed. I couldn't get treatment. I hit the bottle. I developed an alcohol dependence problem. I lost contact with my family. I got into debt. I lost my job. 18 months later, I've got treatment. I'm back on track. I've paid off my debts. I'm back with my kids. And now I'm going forward for employment. Somebody else rang in. I've had another blip with my psychosis. The voices have been really, really troubling me. But I have found some new coping ways of dealing with that, and I want to work. So what that entire radio program did is it stopped people talking about mental health, the blob, which nobody understands. Everywhere I go, when people are talking about commissioning mental health or funding mental health, if we say mental health, the blob, people don't know what we mean. If we talk about, like these brave people are doing over and over, more and more, talk about my eating disorder, my alcohol problem, my OCD got bad, my depression, anxiety, my PTSD, what that is doing is educating the members of the public about, A, the fact that mental health, we cover a lot of ground. It's not just one tiny thing, it's a range of things. Secondly, we're busting the myth that it's fine to talk about having cancer or having a hip replacement, but you can't talk about your mental health. We need the same parity of being able to express what's going on. And thirdly, it is busting all the terrible prejudices and myths that say if you have a mental health problem, you don't want to work, You don't want to be a contributing member of society. So I take my hat off to all those people who are very brave and are speaking out for mental health, because they are making the biggest impact on the stigma campaign, I think, of almost anyone. So what's parity? So the title of my talk, I believe, is kind of, so what's the mental health strategy and how is recovery impacting? Well, these are the sort of things people tell me. So I use the word recovery as often as I possibly can in my talks. If I'm honest, I think it's about helping people build their resilience and give them the opportunities to be the person they really want to be. Many of the people that I've seen in my own practice have never had the opportunity to be who they really want to be, and they haven't got anything to recover to. But the principles of building people, helping people build their resilience and get to be the person that in their heart and soul they want to be and recover is very, very dear to my personal heart in my time as National Clinical Director. So what are people telling me they mean by that? Well, people are saying to me that they want parity. Now, we've had and I think debacle is probably the right word, about the monitor deflator thing over Christmas. But I'm talking about clinical, I'm talking about personal care, I'm talking about people recovering. And so what people say, to them, parity means they want, when they have a mental health concern, difficulty, they want people to make sure that they understand that physical health is equally important. When they go with a physical health problem to their GP, into an acute trust, into A&E, into an outpatient clinic, they want to know that their psychological health needs are being assessed and addressed. To me, parity means, and recovery means, that there is parity of power in the relationship between the person providing the support and the person getting it, the person asking for it. So that we need to be giving people better information, better choice, better control over their care. These are all things for which we have very robust plans in the next 6 months. I want to make sure that in mental health, people have the same levels of access to safe, effective, measured outcomes, user voice experience for mental health conditions as they have for physical health conditions. And I personally want to make sure that people who tell me that what they want is care at home, care coming to them, personalized care, aiming towards recovery, we need to make that a commissioning as well as a service delivery reality. And I think the thing that is very different going forward, I think partly because of the economic crisis, but I think people are understanding that we can't continue with the current level of physical and psychological health literacy in the population. Now, there's a lot more push to get physical health literacy. People get gym passes, they get healthy lifestyle passes, they get support. You get your pedometer to kind of measure what you're doing. More and more people can go to Weight Watchers, they can do all of that. What we need is a kind of a psychological health pedometer, because what we need to be doing is helping people's understanding of psychological health and resilience. And I would love us to be able to say that for anybody that comes to any of our services, whether they're peer services or whether they're kind of clinician-driven or whatever, that having been in that service, people remember it for the whole rest of their life. They remember that interaction was something that was so kind, so compassionate, so expert, that actually it made a real difference and sometimes a life-changing difference to their life. I want to be able to look back and think that if people have come under my care, that actually that has been one of the most positive, enabling, supportive coaching experiences that they could ever have. And that's what I think we need to aim for in the culture. So, what exciting things are happening across the country? Well, despite the economic recession, all I can say is that mental health, our world is a world where we celebrate difference. We love innovation. We can think outside the box. Many of us have got the dyslexic brains that kind of let us do that. So mental health is on the move. There are kind of 3 major strands of work. I mean, there are more, but I think if I keep it to 3, it makes it a bit simpler. One is there is now a major movement about tackling the causes of mental ill health, about building literacy, about recognizing that community resilience is key to recovery. There's also some of the most interesting email conversations at kind of 11 o'clock at night, I have to confess, are with the primary care mental health movement. It's extraordinary. They've just appointed a new mental health lead in the Royal College of GPs. The man's already set up diploma courses, postgraduate courses for GPs. There are amazing things happening I'm just going to allude to. And then finally, people who are in the what I call specialist services provision. I think that's where you guys have led the most utterly extraordinary movement. But I would love to get you to help me move it into these other areas as well. I don't think I need to rehearse these slides, but this is one of the things I would urge every one of you to do is to get your slide pack. Get your small slide pack that when you get to give talks anywhere, you can articulate. We speak with a common voice in mental health. We have a common message. These are the facts. This is probably a summary of about 2,500 research papers, but it's presented in a way that says, in mental health, we do not have parity of physical health, care, or survival for people with long-term mental health conditions. On our watch, in our services, working with or without or not in partnership with local primary care and acute care, our service users are dying 20 years early. This is wrong. This is wrong. This is on our watch. We can't blame anybody else for this. We have to find a way to change that. Secondly, we know that only 25 to 30% of people with common mental health problems that have a big impact on them and their families and their children get access to any kind of care or treatment. That's what I'm certainly on a mission to change. So let me just very briefly, I suppose as a kind of someone who in her heart is really a clinician, I can do the politics, but in my absolute heart, I love being with people because I have learned so much that has helped me in my life be the person I want to be and be strong at times and resilient in these roles because of the people I've worked with and what they've taught me. And I just want us to think, when you talk about mental health as a blob, people don't understand what we're talking about. When you talk about, these are the common reasons why people present with their general practitioners, present in society with mental health problems. How much of this is something that peers support, that better politics, better society, better communities could prevent and address? There are things that, isolated women with kids, children at school who are being bullied, the dyslexia has not been treated, elderly people alone who become depressed because they're isolated because transport's not good. As a society, how do we help people prepare for transitions, divorce, even having a child, redundancy, menopause, alcohol and drug addiction, wonderfully rising to the absolute top of the agenda again. How many people develop an alcohol problem because of untreated depression or anxiety? People are beginning to understand the causes. Healthcare is beginning to move to let's understand why people are getting into these situations and stop investing just so much money upstream. Let's look at this. I'm not going to go through all of these, but I just want to say that, so what's happening at national level that hopefully will be helpful to the recovery cause wherever someone is in that mental health journey? First of all, major movement on employment. Cabinet Office have had a review of employment policy, a review of the levels of access to healthy employment practice, and things are really moving. Let me give you an example of how whole communities are working together. So in an area in the country, which shall be nameless, their IAPT service noted that a lot of people being referred were coming from a particular employer. So they went to that employer and they said, look, can we help you with some healthy employment practice? British Telecom saved £3 million a year by putting in place healthy employment practice. And the company said yes. And the company had such a massive reduction in people being absent from work, lack of productivity, people going off sick, that actually the company then said, this has been so successful working with you guys in healthcare that we would like to now offer 30 places, supported employment places, for people who've had more difficult, severe challenges in their life. So that spirit of, I think what's been called alliance commissioning, working together, that is just blossoming everywhere. We're working very hard with Public Health England to help them help local authorities commission things like positive parenting programs. school nurses, health visitors trained in health promotion, building resilience, prevention of mental ill health, recovery type practice. I think one of the most interesting things I've heard in the last week, I've now heard of the 3rd chief constable of police in an area who has heard the word, heard that young kids with conduct disorder, what causes it, how often they go on to have lives that are adverse because they'll get involved in criminal activities, they'll end up in the criminal justice system. And 3 chief constables are now funding parenting programs for troubled kids, for kids who've got conduct disorder. So this kind of responsible community commissioning and working together is beginning to bite. I won't go on about the rest of it, but I'm not going to go through the detail in this slide, but I want to leave these slides with you. Primary care mental health. I think it's probably fair to say that compared to other first world countries like Canada, New Zealand, Australia, parts of Scandinavia, Hungary, we have not in this country been able to support primary care with their 10-minute appointments in the way we'd like to. So primary care mental health is exploding. Examples of the sort of things that are developing across the country at pace are masterclasses between specialist health providers and primary care, practice nurse cascade learning, 800 out of 1,400 practice nurses in London trained in the care of people with SMI, the physical health care, safe medicines monitoring, 800 out of 1,400 trained in an 8-month period using a cascade model I can happily share with you. Places like Swindon, having direct access to psychological assessment, and then having integrated physical and mental health programs. The language that's been increasingly used is living well after stroke courses, adult education funding, living well after stroke rehabilitation. We have people waiting for appointments in IAP now doing a kind of a managing your mood courses, programs. Adult education is on the move to help us if we can maximize those opportunities. And passionate about people with severe mental health conditions are a whole batch of CCG mental health leaders who are developing 10-year, 5 to 10-year enhanced schemes, local enhanced schemes, DESs or LESs. What's an enhanced scheme? I can see some of you looking really puzzled. Well, it goes something like this. If, for example, you work in Hackney, where one of the leading CCG mental health leaders is, Rhiannon England, what you commission is you want your whole CCG to actually be special for people with SMI. So what you commission is training for every one of the receptionists. So receptionists know when someone comes in the practice what that might mean. Employing additional practice nurses who will do really rigorous, systematic, kind, gentle, enabling physical health checks and healthy lifestyle promotion. GPs with a special interest in mental health who've now gone through a CPD postgraduate training program. Commissioning third sector and peer support workers who will go out to people's home to do the outreach that we need to bring people in to get their care. And third sector IAPT and employment support services, all working in complete collaboration with local specialist providers who come and do outreach. These are some of the just incredibly exciting developments that are starting across the country. Enhanced schemes for people with, in inverted commas, I hate the term, medically unexplained symptoms. So people who have been to the acute trust over and over and over again, had more and more X-rays, MRI scans, long investigations, because the fundamental underlying distress, depression, anxiety, OCD, abuse history that's never been dealt with hasn't been recognized. That's very, very recognized as something that primary care really wants to work with secondary care, work with specialist IAP providers to deal with. So again, I can send you lots of information on those things. And then finally, because I can see Jeff's getting itchy, understandably, what are the big things on the block that we've done this year to help support your recovery movement? First of all, as you know, we've set a CCG outcome indicator lever. That means that CCGs will be rewarded for commissioning for people to get back into employment and recovery. We need your help with that. At the minute, I have no resources. We have no resources for an implementation plan. IMROC could really help us lead that. We also, this year, my personal passion is to make sure that we really understand why we're detaining people under the Mental Health Act. Is it all necessary? Is there another way to do this? For the first time ever, we will be able to give you next month, CCG by CCG, local authority by local authority, the numbers of people detained under the Mental Health Act. 1 to 3 times, 5 to 10 times, more than 10 times. I would urge IMROC to help us, when we get this information, help services think, work out how do we work with people who've been detained over and over again? Is there another way to kind of address that? And the final thing that I really want your help with badly is the physical health sequence. So one of the things we managed to pull off was getting a national, for the first time ever, we have a national mental health sequence dedicated to us. And it's about physical health. It is the largest ever international improvement program. I'm petrified, to be honest, because we really need to deliver for people. So from April, all 22,500 people in every single solitary type of a mental health bed in this country will have access to, and we need to organize it, basic physical health assessments and interventions. I would love it if you, the IMROC movement, can help us get a recovery focus to the way we deliver that physical health interventions. That it's not, it's about behavioral health, it's about normalization, it's about helping people socialize, it's about helping people do employment, all the things you do so well. Please, can you help us do that in the physical health sequence? And finally, I think the words that nobody's noticed in my physical health sequence is that it starts off by saying that every single person should have a co-produced formulation. Now, I think people haven't quite noticed that. I'm kind of waiting for the reverberations, but I think you know what I mean, so that every person who comes in contact with our services is worked with in a way that there is a shared understanding about their issues and therefore a shared agenda about recovery. So I'm here asking for your help, and thank you so much for the energy that you have dedicated to your cause, and I really look forward to working with you over the next couple of years.
Well, thank you very much, Geraldine.
Thank you, Jeff, for inviting me, and good morning to you all. All I can say after that talk was, wow. I'd love to see what you do when you're not having an economic crisis. Very impressive. So, I'm very pleased to be here. Every few months I get emails from Jeff Shepard or Glenn Roberts or someone affiliated with IMROC showing me their latest PDF or their latest article, their latest product, and it's always very helpful to me because I take those to my government back in the US and I say, why aren't we doing things like this? This is what we need to be doing. So I'm very pleased to be a part of that this morning. I was asked to talk about peer support and integrating peer support into the NHS services as well as the voluntary sector, because I understand you've hired a lot of peer support staff and you intend to hire even more. How many folks here are peer support staff? Oh, not as many. Okay, well, welcome. Nice to have you here. By the way, there are seats up here in the front when more folks come in, just so you know. There's empty seats over there. Well, I'm going to talk briefly about peer support, the history, but I want to spend more time on the other three topics here. And I may not get to everything, and I will be happy to give my slides to the IMROC team, so if you want to see what you missed or what I didn't have a chance to cover, they'll be available. But after that, I want to distinguish between engaging people into treatment, which is one thing peer staff have been shown to be effective at, but I want to distinguish that from engaging people into their own self-care. And actually, Geraldine mentioned this around health literacy. So this move towards self-care is not just specific to behavioral health. It's also in general medical care. But we have certain challenges to engaging people into their own self-care that I will talk about in a few minutes. Then I want to talk specifically about what peers can do to promote self-care in the people they work with. And then finally, what are some of the concerns that non-peer staff typically have about working with peer staff and how those can be addressed. And I have about 40 minutes. Jeff, you'll tell me when it's 40 minutes to do that, but feel free to interrupt me or to ask questions as I go if what I'm saying is not clear. And I will try not to talk too fast because I know I have a heavy American accent and you may not always be able to understand me, but I'll try. Most people think of peer support as a fairly recent initiative that came to be in the late 1980s as an outgrowth of the mental health consumer survivor service user ex-patient ex-inmate movement. And that's true. It has in its recent contemporary form come from the service user movement. However, I was fascinated to find out that it actually goes back to 1793. You see that picture. It's a famous picture of Philippe Pinel, the father of psychiatry, unshackling female inmates at the Salpêtrière in France. And this was promulgated as a sign of the French Revolution, of liberty, the liberty, fraternity, whatever. Turns out, if you go back to Pinel's own writings, he arrived at not the Salpêtrière, but the Bicêtre was the first hospital in Paris that he was the chief medical officer for. And when he arrived there, he found a superintendent, named Jean-Baptiste Poussin, who had been a patient at the Bicêtre. And once he recovered from his physical ailment, it was a hospital that not only served people with mental illness, but physical illness. He was hired to be a ward on one of the mental health units. And he proved himself to be so adept at working with people with serious mental illnesses that he became the superintendent of the hospital. And he was the one who first started to unshackle the patients, the inmates or the patients there. But one of his primary management strategies was to hire people in recovery to staff the mental wards. So peer support actually goes back to 1793 in Paris. And there's been a long history of peer support. Harry Stack Sullivan hired his own recovering patients, to staff his wards in Baltimore in the 1920s and 30s. So if you look back in the history of mental health, you will find the role of peers throughout that history in more or less obvious ways. So we've sort of overlooked Poussin's approach of hiring people in recovery to staff his hospitals. Dorothea Dix, the American crusader who founded the state hospital system, had had her own episodes of psychosis. She had been treated in a retreat in London, actually, and gone back to the US, crusading that other people be offered the kind of compassionate care that she had received. And the therapeutic community movement that was very alive in the 50s and 60s had roles for unpaid peers. The majority of your recovery was through your interactions with other patients, but nobody got paid for that at the time. But now we do. And the first thing I want to offer you, other than that, is some evidence. So if you're still heavily involved in promoting evidence-based practices in the UK, which I understand you are, it's important to know that since the 1980s, there has been a growing body of evidence. The first generation of studies, starting in the early 90s, showed that it was feasible to hire people in recovery to serve as staff. Now, you may find that laughable now, but being one of those people who started hiring peer staff in the early 90s, I was laughed at, and other things that I won't get into. But the idea that a person with a serious mental illness could be hired to provide services was a very revolutionary idea in the late 80s, early 90s. So there were a series of studies done just to show that it was possible. The second generation of studies compared peer staff with non-peer staff doing conventional roles like case management, and showed once again that people in recovery could provide care at least as well as their non-peer colleagues, and could show some benefits in terms of reducing readmissions. The third generation of studies, which are underway now, are investigating whether or not there are unique contributions that peer support makes. And so far, we have found that peer support increases hope, decreases drug and alcohol use, and especially for our purposes today, activates people to become more involved in their own self-care. I'm not going to go through all these, but I want to show you that we have found peer support to increase the degree to which people feel involved in their own care and collaborating with their providers. It's improved their social functioning. It's decreased significantly their use of drugs and alcohol. The yellow line shows that when offered peer support, people will make more use of outpatient services. The reason there's a block there is I want you to predict where the yellow line goes next. So over the first year of receiving peer support services, people will engage more and use more outpatient mental health services. There's a concurrent decrease in inpatient use and an decrease in inpatient, increase in outpatient use. Where do you think the yellow line goes after that?
Lower.
Sorry? Down, yes. After people are no longer working with peer staff, they go back to not using mental health services. So this is disappointing to some people. To me, it was more confirmation that it really works. Because if we're talking about people with long-term conditions, you shouldn't take services and supports away from them after a year and not expect them to have more difficulty. The analogy I use is I've been wearing eyeglasses since I was in the 7th grade, so I was 12 years old. No one at any point in the last 40-some years has said to me, your turn is up, give your glasses to somebody else. Other people need glasses too. Obviously, those glasses haven't worked because you still can't see without them. Peer support, in a lot of ways, are like glasses for people who have visual impairments, and I'll come back to that later. But just so you know, I see that yellow line falling back as more confirmation of the power of peer support.
The trouble is, in this country, the mental health service seem very desperate to discharge people.
Yes. Resource allocation. I understand that. I understand that, and I'm really happy to be with a friendly audience this morning. I should have said that before. It's really nice to be among like-minded people. Jeff and I had the opportunity about 4 months ago to talk with not such a like-minded group who tutored us on how recovery is now being used as a way of denying people services. Please know that recovery was never intended to be used politically as a way of denying people services. This was addressed recently in an article by Mike Slade in the World Psychiatric Association, I think, as an abuse of the term recovery. This is not what it was intended to be used as. Geraldine mentioned people who are multiply detained. Connecticut is one of the few states in the U.S. that does not have outpatient commitment statutes or mandated outpatient treatment. When there was a murder in Connecticut by a person with a serious mental illness, the legislature wanted to put in place outpatient commitment orders under the false impression that mental illness causes violence, which it doesn't, which we won't get into today. But we were able, the recovery community really was able to lobby the legislature to try peer engagement as an alternative to outpatient commitment. And here we are 15 years later. We don't have outpatient commitment. We have hundreds of peer staff. And we've been able to show that peer staff have a particular talent at engaging the unengaged. And again, for our purposes today, this was a study of peers facilitating person-centered care planning and community inclusion. And you'll see the items in black. They increased the sense of control people have and their sense of being able to make changes in their lives, increased their sense of the responsiveness of treatment and the inclusion of non-treatment issues like jobs and housing and school and friends in their care planning, and engaging in managing their illness. These are all the important things that we're getting to. And finally, I think this is the last one. This was one of those third-generation studies that showed that peer mentors reduced readmissions by 42% and reduced days spent in hospital by 48%. And the addition of peer mentors decreased substance use, decreased depression, increased hopefulness, increased self-care, and increased well-being. So there is an evidence base, and if anybody wants to see it, there was a very nice article just published, or in the process of being published now, actually, it's online, by Matt Chinman and his colleagues in Pittsburgh, published in Psychiatric Services that did a thorough review of this literature. So there is an evidence base. But what are people doing? All of that was a prelude to saying, well, what is it that peer staff do? And why is it so effective in those areas? And I want to differentiate here, and I mentioned it already, that traditionally, like 15 years ago, it's not a long time now, but early on, people with peer staff were assigned to engage in care people who had refused or been reluctant to engage in care. And this meant, initially, getting them into treatment, engaging people into services as they exist. That's not the same as engaging people in self-care. And where peer support is moving now is more toward engaging people in self-care with or without the support of treatment.